some short time to question and answers because we don't want to steal the time from the other presentations following. So let's have 3 very concise questions with 3 very concise answers by the presenters.
My name is Christopher Lexer from Erlangen. I would like to ask Dr. Würtner, first of all, thank you very much for this very interesting talk. Concerning the fact if all we are here, we want to translate new drugs into clinical trials, it's necessary to convince industry because otherwise we don't bring them into a broad field into clinics. What is a realistic time frame from your standpoint of view? How long would you support a research from the idea of a new drug to come into clinical trials? What is a realistic time frame from the industry point of view?
So let me just try to get this right. So when we start with new target identification and then develop new drugs and lead optimization and so forth, I believe the time frame for that before we actually enter clinical trials, which is where I come into the picture, is between 4 or 5 years or so. Can be longer, maybe sometimes can be shorter. So if we're really talking about a new drug, it might be different if you're talking about a new formulation that you already have your active ingredient, you just want to package it in a different way. That could be quicker, and that could also come later, right? You could start with your initial formulation, and then if you have something better, you could try to make a switch during clinical development.
Okay, Jacinto.
My question is to the second speaker. Don't you think that major reasons for the delays in developing drugs is due to the slowness of feedback from the patients? When you look for metastasis progression, instead of having a fast feedback, you have to wait for months, and therefore you cannot develop drug on that time scale.
So the question was that one challenge is that the feedback from patient trials involves a long time delay during the development phase. And if you believe that this long delay of patient feedback, of patient data, are one of the roadblocks in drug development.
Well, yes, obviously that is a challenge, and I mean, it's still until this day very recently where the MET inhibitors, the antibodies that recently in phase 3 trials failed while all the earlier clinical trials were positive. And then the question is, how do you avoid that? And I don't think you can always avoid it. Obviously, we're trying to find more specific, again, biomarkers, if you will, that indicate early on whether something has legs to stand on. But I don't think this will entirely this will go away. I mean, you always look for new targets, and when you have a new target, then you will need to reevaluate it, basically a new biomarker. And I don't see a solution for that. But if you have one, let me know.
Hannover.
To Dr. Clark, aspirin turned out to be an extremely efficient chemopreventive, mostly for colorectal carcinoma, based probably on the fact that these people suffer from subclinical inflammation and you suppress it. So unlike rheumatoid arthritis people, they don't have any symptoms. So how in a large population you sort out those that suffer from subclinical inflammation from those that don't suffer, and will you recommend for the suffering ones, based probably on biomarkers like high level of inflammatory mediators, chronic intake of aspirin?
That's an excellent question, and one I find it quite difficult to answer. I'm not sure what biomarkers would exist in order to discriminate between those two patient groups. But I think there's an enormous promise coming from metabolomic studies, and my colleague, for example, Steve Young, who's leading this in Birmingham, are discovering that there are readily recognizable metabolic markers of pre-syndromes, of pre-disease syndromes. This certainly seems to be the case in rheumatoid arthritis, and I think there's a lot of very active research going on in different cancer fields as well. So it may be possible to stratify your patients according to that sort of system before you make your recommendations. And I think that's where the progress is going to come, so that you can actually intervene long before the patients are presenting with symptoms. I suspect that will be the development.
Let me now pass the chair to Professor Renato Paro, Chairman of the ETH Zurich Department of Biosystems Sciences and Professor of Biosystems at the University of Basel.
Thank you for handing over.